we'll get started. We waited a little 5 extra minutes in case the plenary took a while to get here from there. Today we are going to be presenting on Let's Be Blunt, Cannabis Use in CF. My name is Corey Muirhead. I'm the pediatric cystic fibrosis pharmacist at Dorenbecher Children's in Portland, Oregon. Katie is my co-chair, and she is the nurse coordinator at Phoenix Children's. And today we have 4 great speakers with 4 great talks. And here are our, we have no disclosures. So our objectives are to review differences between THC and CBD, analyze cannabis usage, develop strategies for dialogue. Please use the app to ask questions or come to the microphone. And we'll field questions for each speaker at the end of their talk. Our first speaker is Dr. Hannah Phan. Her title will be The Latest Decree on THC. Dr. Hannah Phan is a clinical associate professor in the Department of Clinical Pharmacy, College of Pharmacy, and faculty affiliate for the Susan B. Meister Child Health Evaluation and Research Center at the University of Michigan. Dr. Phan practices as a clinical pharmacist specialist in pediatric pulmonary medicine with a focus in cystic fibrosis at C.S. Mott Children's Hospital, Michigan Medicine. Prior to her return to Michigan, she served as faculty at the University of Arizona Colleges of Pharmacy and Medicine, as well as associate research scientist for the UA Asthma and Airway Research Center. Dr. Phan received her Doctor of Pharmacy from the University of Michigan and completed a postdoctoral fellowship in pediatric pharmacotherapy at the Ohio State University. Dr. Phan's current research interests include patient caregiver medication education and self-management, medication use in schools, and interprofessional care of children with chronic conditions such as cystic fibrosis and asthma. Please welcome Dr. Phan.
Okay, thank you so much for the introduction and for the invitation to speak on a very interesting topic. I'm sure we'll find a lot of interesting findings from today's various speakers. So just to make sure that we're all on the same page in terms of terminology, here are the various acronyms that we'll be using, including THC, CBD, and anything PO or inhaled. We're going to go over the timeline of legalization as well as decriminalization of cannabis. We'll talk about the different trends of the use of specifically THC in the CF community based on some preliminary survey data that I'll present. And then current data that exists in general and not specific to the CF population, but the use of THC for the treatment of pain, anxiety, and sleep. All right, so some additional terminology and definitions to go over. So herbal cannabis means the whole plant or parts of the plant. Medical or medicinal cannabis is the plant itself, materials, or any extracts for medicinal purposes or medical purposes. And then cannabis-based or derived medicines are those that we may see that are pharmacologically made, manufactured. And then, of course, cannabinoids, and then phytocannabinoids are those that are found in the plants or the extracts from the plants. And endocannabinoid are endogenous ligand found in the body, which have an affinity and activity at the cannabinoid receptors. So when we're talking about this topic, cannabis, we need to think about legalization and decriminalization. And we know amongst our different states, there's different laws and whatnot, and we'll go over that. But legalization is where the process, it kind of implies that some type of legal supply and the process of removing all legal prohibitions when it comes to cannabis, making it available to the general population, similar to what we see with tobacco and alcohol. Decriminalization is different in the fact that it is the act of removing criminal sanctions, such as having the possession of cannabis. But it is still prohibited generally. It's just not, the repercussions of having it or carrying it are no longer considered criminal. And so when we think about those different classifications in terms of legalization being medical and recreational, no defined legalization as of yet, and then decriminalization, it has varied from state to state. So we can see here, these states here have medical only legalization of cannabis. States here, including Arizona, have medical as well as recreational. And then at the point of when I pulled this data on the 7th, the defined legalization was not clear in these following states. And then it was decriminalized in these states who may have also be in the non-defined legalization category. And of note, some of the categories may have limitations in terms of what they consider legal cannabis in terms of THC ratio to CBD ratio as well. So the federal status of cannabis. At the federal level, cannabis remains a classified Schedule I substance under the Controlled Substance Act. And this is where they're considered to have high potential for dependency and no accepted medical use, et cetera. In the early fall of 2023, the Department of Health and Human Services asked the DEA to reconsider the classification to a Schedule III, and this is still under review. So, what do 30 hydrogen atoms, 21 carbon atoms, and 2 oxygen atoms have in common? They both comprise THC and CBD. However, they're structurally slightly different, as we can see here. There's one important difference. In the THC, there's that cyclic ring that you see on the left, and CBD has the hydroxyl group. And this small difference in molecular structure attributes to the different pharmacological properties of the two different compounds. And so what specifically is THC? We consider that more the primary psychoactive cannabinoid of cannabis. It binds to the cannabinoid receptors of CB1 and CB2, primarily in CB1. The synthetic forms of THC that you may find in terms of pharmacologically available are listed here on the right, including dronabinol. And CB1 primarily focuses on the central nervous system, whereas CB2, where it is a weak receptor, is the peripheral nervous system. And it affects various things in terms of emesis, appetite, and pain, and that's mostly attributed to CB1, and modulates sensory, somatic, and cognitive perception as well. So, yes, we know what THC is, but did you know that there are various THCs? So this is a tale of two THCs. Delta-9 is the major cannabinoid found in cannabis, and it's easier to extract. It has a really high affinity for the CB1 receptor, but it does have greater psychoactive, including adverse effects. It is less permitted per state laws, and so again, that limitation of the type of THC and the THC ratios. It is less popular in products because of that legal issue and can be synthesized, but typo, dronabinol should be in Delta-8, sorry. Delta-8 THC, I like to consider it kind of like the nicer younger sibling of Delta-9. It's found in lower concentrations in cannabis, has a lower affinity for CB1, but it also has less quote unquote high effects or psychotropic effects or psychoactive effects as compared to its sibling Delta-9. And so it is increasing popularity in products and has a little bit broader availability in terms of legal status, and again, is easily synthesized as well. So if you think about Delta-9 being the fun sibling and Delta-9 being the more responsible sibling. So this was a project that one of my past residents did. We did a survey thanks to the CF Community Voice and Cystic Life listservs. We disseminated a survey to people with CF and caregivers of people with CF. And this was done in the early spring of April of 2020, so right in the midst of things. And we asked a bunch of people to ask questions regarding their use of cannabis or their consideration of use of cannabis. We had about 410 respondents in total. So as you can see here, we asked in the last 12 months, so prior to spring of 2020, were you considering the use of any products containing cannabis or related to cannabis? And as you can see here, we have about 46% of adults with CF stating yes, and then almost 50% as well. People with CF, their caregivers reported that they've actually considered the products. And then when asked further what type of products were being used or considered for use, we have about almost 46%, 47% stating cannabis, and then in terms of consideration of use, equally cannabidiol or CBD. So why are populations in general considering the use of cannabis? So there's various reasons for people to consider it, and the most popular reasons we'll talk about today include pain, anxiety, insomnia, and then also appetite and gastrointestinal issues, which our subsequent speaker will speak about as well. And so when we think about the updates in terms of what the data is on cannabis and pain, there's various types of pain and conditions in which this has been studied to some degree in human studies as well as animal models. That includes cancer, multiple sclerosis, sickle cell disease, and fibromyalgia. Unfortunately, a lot of the data on these various topics are not very CF specific in terms of population, but I'm pulling the data so that we can look at both the safety and efficacy data that's out there. In terms of that human and animal model data that we have, there are some clinical trials that have been done in humans, inhaled form, such as inhalers, as well as oral form in terms of cannabis. And there are also data available in the forms of systematic reviews and meta-analyses for both the combination of human and animal trial data, including mice models. So what do we know from the current data so far? And so these are the common themes that I saw in reviewing the literature and the current data. So when it comes to the inhaled form, which is the less preferred form as we are talking about pulmonary medicine, it does have a quicker onset and a shorter duration of analgesia effect, which is probably a partially reason why folks elect to use it because of the quicker onset. And it has a synergistic and antagonistic relationship, a love-hate relationship with each other between THC and CBD. And when we're talking about synergistic pharmacokinetic, that's how the body processes the compound. And then when we're talking about antagonistic pharmacodynamic, that means how the compounds affect the body. And in terms of the findings, I will say that there's a lack of consensus in terms of dose, duration, formulation, et cetera. And the common theme across all of the data that was reviewed was that there was no known long-term effects, and some of the studies only included as little as 1 dose. And so we really don't know what the long-term effects are. There was also the question of pharmacological study dosing, so a dosage form that is produced for pharmacological reasons to be produced by a manufacturer someday and dispensed as a prescription, versus its equivalent, if there is one, in a commercial product that you can see at a cannabis shop. So there's no way to translate the dosing accordingly. When it comes to the oral form, data has suggested that it can possibly help with short-term chronic pain improvements, specifically in certain populations such as cancer, but the formulation needed to have a high THC to CBD ratio, and those were found in oral synthetic cannabis products, or if it was a sublingual formulation and it was extracted from plant and it was more of a 1-to-1 ratio. And so with the higher ratios come risk, including increased adverse effects, including dizziness and sedation, and again, the common theme of unknown long-term effects. Many of the studies that were studying oral forms as well had single dose or only a few doses and not long-term months or years dosing. And again, the variability in the dosing formulation, even the plant source in terms of the type of plants, if they were using a plant product versus a synthetic. In terms of anxiety, the use of cannabis and its popularity has risen, as we know, but did you know that THC has actually anxiogenic properties, meaning it can actually cause anxiety? And it is dose dependent, and some literature has suggested that it's biphasic. So at a certain dose, it can be anxiolytic to a certain extent and then go to the point where it gets anxiogenic and back down to anxiolytic. CBD has more of the anxiolytic properties and also has that biphasic sort of appearance in terms of the modeling and data. There's both human and animal data out there, more so animal than human, but it was found that more CBD was helpful in terms of reducing anxiety versus the THC ratio. And epidemiological data found that in products that had both THC and CBD, that it could be potentially anxiolytic, but depending on the ratio, and then anxiogenic if you had pure THC in high dose. And so when we think about the different formulations, again, thinking about THC versus CBD, when it comes to the CBD dominant formulations that were tested and reviewed, that has a wider therapeutic index for intoxication, meaning you could use more of the medication or dose of CBD before you would reach intoxication compared to THC. And the observed side effects from clinical trials included diarrhea, changed appetite, mild sedation, as well as drug inhibition with regards to cytochrome P450, 2C9, 2C19, and 3A4. When you think about the THC dominant formulations, there's considerably less data on this in terms of safety and efficacy in treating anxiety. And some studies have suggested that it exacerbates anxiety, contributes to depression, even leads to psychosis and potentially suicidality at high doses. And the observed side effects in clinical trials, especially those that had delta-9 THC, included euphoria and altered sensory perception, increased appetite, dizziness, sedation, as well as potential for drug dependence. With regards to sleep, the potential sedative effect comes from the neuromodulation of the partial agonism of THC at CBD1 receptors at the basal ganglia. But as we'll see in our subsequent speaker, that CBD also has potential for sedative effects, as it has an antagonistic effect of both CB1 and CB2. Some believe that cannabis for sleep has its advantages versus pharmaceuticals such as like benzos or other sleep agents, and has a safer profile. But as soon we'll find, as we talked about before, it depends on the ratio in terms of THC to CBD. And unfortunately, there's a lack of high quality clinical trial data in the area of cannabis and sleep. So what do we know so far from the current data? There is a study out there that looked at cannabis and sleep outcomes, and those that actually endorsed the use of cannabis via survey response and had reported increased use, noted that they had increased expectation of improved sleep, but when they looked at their sleep scores, they actually had worse quality of sleep. And the frequency of use of THC and CBD was not really associated with sleep outcomes based on this study. And the increased use of edibles found that those that used edibles more, reported worse sleep efficiency overall in terms of subjective scales, lower sleep duration, and overall worse sleep. But there was also another study that looked at age and CBD specifically, and that if you were of a certain age, 31 and older, and use CBD, that it could potentially help with sleep duration and quality. There was also a systematic review looking at dosing and administration of cannabis specifically in sleep, and looked at various clinical trials and studies, and they found that they noted sleep improvements in 7 out of 19 randomized trials and 7 out of 12 uncontrolled trials. They found that the higher dose was possibly needed, but that also paired with high risk of adverse effects, as we talked about with THC, and that the most promise for use of cannabis in sleep were in pain-related disorders. As we noted when we talked about pain, pain-related disorders versus neurologic disorders, psychiatric, or even sleep disorders. So those who have chronic pain may benefit potentially versus those others. And again, the variability in terms of the strains of cannabis that were used, the dosing, the formulation of which they used them, the timing in which doses were administered, as well as even the sleep outcome measures that were measured for a lot of these trials in the systematic review were noted. And so that lack of consistency is concerning. And so the current data and limitations and ongoing questions. So good quality larger trials are lacking. Upon reviewing the literature and looking at cannabis specifically and with THC, a lot of it was either model data in terms of mice and either reported data in terms of surveys and things like that with patients, and then the small clinical trials of inhaled and oral with like single dose or multiple dose studies. Again, the wide variation in terms of the interventions from strain, dose, et cetera, in the clinical trials, and the unknown point of long-term safety. There's a lack of data specifically for people with CF, including the risk of drug interactions and drug disease interactions. And there's still a gap in terms of the translation, in terms of the form of a product that is to be dispensed by a pharmacy, for example, if it was turned into a medication form, versus those that you would find in a commercial product in a shop or a store. So knowing that there are products out there and that there are wide variability in terms of availability and legalization across the country, we want to know how are people with CF using cannabis? And so when asked this question, about 9% said they were smoking, and about almost 60% consumed it by mouth, eating edibles and things like that. And then some mentioned things like topical things such as CBD oil. And so there's a wide variety of products out there. If you were to step into a cannabis shop in Arizona, you'd probably find various things, including vape pens, ways to inhale it, ways to ingest it in terms of various edibles. There's even tablet forms as well as tea. But do note that the dosing between the various forms are not necessarily one-to-one. They can be very drastically different depending on the strain and the concentrations. And so, again, not equivalent or interchangeable from one to another. And so what are people using? Are they more inhaling or ingesting, and why are they doing what they're doing? And so when asked why inhaled versus eating or putting on the skin, those that replied that they inhaled cannabis stated that they felt that it worked better, about a quarter of people. The other quarter had other reasons, including various reasons in terms of cost, was about 13, 14%. About 12% said it was easier to use. Another quarter said it was easier to get. And so why? Why inhaled versus the oral agent? So many of my patients have told me that if they're electing to do it, it is due to cost. Inhaled formulations tend to be lower cost than edibles in general, and then inhaled supplies can last longer because you can titrate your dose accordingly. And this has been reported in various literature as well when patients are asked about their use. There's also different efficacy. So there is a difference in bioavailability between inhaled versus oral. With oral formulations, depending on how they're made and formulated, you can have erratic or inconsistent pharmacokinetics in terms of how that oral formulation is processed in the body. And so there is, again, that gap and need for additional research. And then there's a slower onset with oral versus inhaled, as mentioned before. And as far as the additional effects seen, there's also this, what we call an entourage effect, and that comes with the different interactions with the different cannabinoids in the plant. And so how does THC interact with CBD, interact with the other different cannabinoids in terms of formulation? So there are safety considerations about THC, and this has been posted by the FDA. There's been notifications from the FDA about adverse events reported with THC-containing products, including psychoactive and intoxicating effects. And the products often used to create are in the Delta 8 as well as Delta 9 in the marketplace. As always, you'll want to make sure to keep products out of reach of children and pets. That's also been reported, unfortunately. And so making sure that we're being safe about the use of THC. There are drug interactions potentially to consider with THC, more so with CBD, I suspect, as my subsequent speaker will talk about. When we're talking about THC as an inhibitor of these various enzymes, it's actually not an inhibitor or strong one for 3A4, which is a common one that we worry about in drug interactions, but it can have potential to be an inhibitor for 2D6, 2C9, 2C19, and 1A2 and 2B6. So there'll be more drug interaction talks in a subsequent talk. But do know that THC is a substrate of 3A4 and 2C9. And so other drugs that a person may be taking can increase the THC levels in them. So if someone were to take an inducer or inhibitor and they're using THC, you could have higher levels or lower levels of THC as a consequence. And so knowing that this is out in the population, that people are using these products, how often is this happening? We had a paper previously about what team members are doing in terms of inquiring and screening about it. In our survey, we asked, how often does your CF care team ask? And about 62% said never. But when we asked subsequently, are you comfortable talking about it if prompted? 34 and 18% said comfortable or extremely comfortable talking about it. So again, maybe we should be talking about it a little bit more openly. Some take-home messages on THC. I wish I had more data for you in terms of specifics of what dose and where to look for and things like that, but the legal status is something that is ongoing. We'll see what the decision is with the DEA. The safety and efficacy in terms of pain, anxiety, and sleep is variable, and so use is, my recommendation is to use with caution. If used, to talk about it freely and openly about it so that safety monitoring can be done. And that the safety of commercial cannabis products, as you can find in various commercial stores and things, vary from product to product. They lack regulation in terms of what's in the products itself. And so there's that concern as well. And the use of cannabis is not a new topic, but we need to continue to look at the trends and have that open conversation so that we can have co-production of care going forward. Thank you very much.
Sure.
Okay, so can you guys hear me? We have some questions that have come in on the app. Does cannabis have, if any, drug interactions with Trikafta, given that Trikafta has been reported at times to have a correlative relationship with anxiety, and cannabis often can have the paradoxical effect causing anxiety?
That is a great question. So if we're talking about cannabis in terms of whole product, including THC plus CBD, there is that potential because CBD does have that potential for 3A4. So you could have that compounded anxiogenic effect with the two together. It is possible.
So second question is similar. What is the dose relationship of THC and the anxiogenic versus anxiolytic? Are higher doses more anxiolytic?
So it's biphasic in nature. Some of the studies have suggested that lower doses, which can be defined in various ways, can be anxiolytic. And then you reach a certain point in which it becomes anxiogenic and it comes back down. So it kind of varies. But high dose THC in general across the studies, more so anxiogenic than anxiolytic. So higher ratio of THC.
All right. And last question, does microwaving cannabis kill mold and bacteria? I'm assuming that would be like plant for inhalation. If so, where do you find this data?
That's an interesting question. That I can't answer. I don't think I've seen any data regarding microwaving cannabis to get rid of mold. I would be concerned if your cannabis has any sort of moisture and you're adding heat to it, then you may be not necessarily killing it, but aggravating the mold to be more prominent. But there's a lack of data on that, but that's a really good question. Other questions? All right. Thank you very much.
Thank you. Our next speaker is Dr. Sarah Fauci. Dr. Fauci is the program coordinator and a certified specialty pharmacist with the University of Louisville Health Adult CF Center and Specialty Pharmacy. She created the outpatient clinic pharmacist role at the University of Louisville Pediatric CF Care Center in 2017 and established her current pharmacist role in the U of L Adult CF Center in July 2019. Dr. Fauci enjoys working with patients to improve medication access and education, as well as optimizing adherence to their regimen. She is involved in several research projects, pharmacy resident training, pharmacy student education, and quality improvement initiatives within her CF Center.
All right. Thank you for that introduction. It's going to be difficult to follow Dr. Fan, but I will try my best. I will be adding to her presentation, but also more focusing on the existing research in CBD. Okay. I have no disclosures relative to this presentation. These are the objectives that we will be covering today. So we're going to look at CBD and its legality, not so much THC. We're going to compare and contrast THC and CBD, review approved formulations and commonly marketed products of CBD, and then look at the existing research of CBD that we have thus far. So cannabis actually comes from the Cannabaceae family. So there are multiple strains. The main ones that you see a lot in the literature are the sativa and the indica strains. The sativa actually has more psychotropic effects and the indica has more sedating effects. So oftentimes they are hybridized to get the various strains that a lot of people associate with whether it has more, the product has more sedating effects versus psychotropic effects. Marijuana, as Hannah previously talked about, has delta-9 THC. It's federally illegal, but the CBD actually comes from the hemp part of the plant. By definition, hemp has a THC concentration of less than 0.3%. It is federally legal, which we will talk about on the next slide. CBD is unlikely to show on a drug test if it's by itself and is considered non-psychoactive. So in 2018, the Agriculture Improvement Act, or also known as the 2018 Farm Bill, essentially removed hemp from the definition of marijuana in the Federal Controlled Substance Act. So it legalized on the federal level the regulated production of hemp or any part of the cannabis plant with a THC concentration of less than 0.3%. States, however, have the final say in whether or not cannabis-derived products are legal within their state lines. So some states still haven't removed hemp from their state's Controlled Substance Act. So legality can still vary depending on where you are in the country. To date, there are 17 states that have legalized both the medicinal and recreational use of CBD as long as the minimum age is met. And then another definition is the Federal Food, Drug, and Cosmetic Act. Its intention is to protect the general public from adulterated and misbranded products that are manufactured and sold in the United States. So the FDA can monitor the labeling, and it oversees the distribution of certain products, which will come into play in a minute. As Dr. Fan touched on previously in the previous slide, or in the previous presentation, the endocannabinoid system is a widespread signaling system within the body. It consists of cannabinoid receptors, so CB1 and CB2, and these receptors are found in various parts of the body. So CB1 is located mostly in the central nervous system, so the brain and spinal cord. So it's located in the hypothalamus, so it helps with appetite regulation, as well as memory and emotional processing and certain nerve endings, and that can be associated with pain reduction. And then CB2 receptors are located in the peripheral nervous system. They help with inflammation reduction as well. So why is this important here? As Hannah mentioned earlier, THC binds to both CB1 and CB2 receptors. And then this has caused the vast majority of end effects from cannabinoids, or your THC, including the psychotropic effects, are from the activation of the CB1 receptors. CBD, however, does not bind directly to the CB1 or CB2 receptors, but it does inhibit the breakdown and reuptake of the endocannabinoids that are already within the body. And then this can translate into various effects further on down the line, including things in the immune system, nervous system, skin. A lot of other things can happen indirectly based on CBD. So I just want to point out the different effects that THC and CBD has within the body, with special attention to the highlighted lines that may pertain more to our patients with CF. So as Hannah mentioned, mental health is a really large concern these days. Many patients do report using CBD and THC for anxiolytic properties, and it has been shown to alleviate symptoms in a few studies. And it should be noted, as Hannah said, that THC can actually exacerbate those symptoms under certain circumstances. So during my research, as you may guess, there are very few placebo-controlled studies that look at CBD versus THC. This is not in a CF-specific population, but it's the only one I could find. So this was a double-blind placebo-controlled trial, and it has 60 volunteers who were randomly allocated into 4 parallel intervention groups. And the subjects were given oral capsules, so they didn't smoke it or anything. It was easier for dosing and placebo purposes. So the patients ate a standard breakfast. They either got placebo or CBD, and then 30 minutes later were either given a placebo or THC capsule. And then about 3 hours later, they had a variety of assessments done on them. So they underwent some neuropsychological tests. They looked at working memory, cognitive processing speed, attention, and an emotional state. And they looked at various things with in the emotional categories. So this is a very busy slide, and all the results that they found in this study are listed here. But the main takeaway from this is that they found that CBD alone did not influence the emotional state, cognitive performance, or attention in these subjects, but THC did actually significantly reduce performance-related activity. It caused patients to be significantly more introverted, and it reduced cognitive processing speed and attention. So why is this topic such a big deal? Why is it so prevalent? And I think as clinicians, we should always have a finger on the herbal side and the over-the-counter products. So this is a very rapidly growing and expanding market, and I'm sure many of our patients are taking these and utilizing these products and perhaps not reporting them to us. So how large of a market is it? So the estimated retail sales of CBD increased by over 300% from just 2016 to 2018 alone. This made CBD not only the fastest growing product category, but also the top selling ingredient in the US natural channel. The collective market for these products is expected to exceed 20 billion, that's billion with a B, in the United States by 2024. To date, there are 439 registered studies on clinicaltrial.gov, and they're looking at the efficacy and potential uses and benefits in various disease states of CBD, with CBD. And the US and the FDA, as we touched on before, with the federal, the FDCA, the FDA does not regulate these products. So there is a lot of inaccurate labeling out there. A lot of things are over-reported or under-reported with respect to their CBD content, or they could contain contaminants or other additional substances. And the FDA, because of this, has issued warnings and letters to numerous manufacturers for false claims. So don't believe what's on the label. So there is one commercially available FDA-approved product of CBD within the United States. Cannabidiol oral solution was approved in 2018 to treat seizures associated with specific seizure disorders in patients as young as 1. And then there is another one, it's basically a 1-to-1 THC to cannabidiol oral mucosal spray, and it's licensed for the treatment of MS-related spasticity in other countries. It is not FDA approved at this time. They are looking at it in a few other clinical trials for like rheumatoid arthritis and certain pain indications, but nothing approved. Although not FDA approved, CBD is found in a variety of other products, similar to what Hannah talked about. This is not an all-inclusive list, but I do want to point out that the oral products, specifically capsules, are becoming increasingly popular due to the convenience of dosing and the better accuracy that patients will get. As well as foods and edibles. There are also teas and creams and syrups. Those can become difficult to dose for your CBD patients. So many CBD containing products may contain other components derived from hemp or contaminants. This study by Spindle and colleagues in 2022 actually analyzed 105 CBD products, and of those, 89 products had actually listed the CBD content. And then they found, when they looked at those, what was reported on the label versus what was actually in the products, only 24% of those were actually accurately labeled related to the CBD content. And there was 58% had actually more CBD than what was labeled, and 18% contained less CBD than what was labeled. And then THC was actually detected in 35% of those products. And of that, 11% actually were labeled THC free. So, this, just be aware that some of these products may actually have THC in them, and this could potentially have detrimental effects for patients who may not be aware that they're ingesting or smoking or whatever with THC if there's a legality or employment issue if they fail a test. As far as research available, as I stated before, there are over 400 clinical trials that are looking at CBD that are registered. And you'll hear this a lot through the rest of my talk anyway, is there's a lot of mixed evidence to suggest the efficacy in many of the uses and indications. And we lack high quality studies. So a lot of the studies that you find in the literature are very small. They have variations in the intervention arms, so various doses, various administration forms, whether it's smoked, oral, topical, etc. And then in 2018, there was a survey that was done that looked at the underlying reasons that patients may use CBD, and these are listed here. So pain, as you would expect, anxiety, depression, and sleep disorders. A survey also showed that over half of those patients or the users used it for more than one reason. So patients are using these for a variety of reasons, hoping that it cures everything. Although not FDA approved, or although it's only approved for 2 severe forms of epilepsy, CBD is used in an unregulated fashion for a variety of indications. And I'll emphasize this again, the studies are mixed, and we definitely need larger, more placebo-controlled trials to further study the benefits and risks of these. And it was difficult to tease out CBD from cannabis in the literature searches. So there's not a lot specifically on CBD without the THC component in there. But this is a summary of as much of the literature that was available. So not really going to go into the specific studies, but just kind of, rated from no evidence, which I thought glaucoma was kind of interesting. I always think of patients using cannabis for glaucoma. There was a very small study, and N of only 6, but actually they gave sublingual CBD to placebo versus placebo in patients who had glaucoma, and they actually showed that the patients who got the CBD had an elevated intraocular pressure. So just food for thought, think of that. There is some positive evidence showing that CBD helps with anxiety, specifically some public speaking tasks. I briefly thought about using that here, but I chose against it. As well as chronic pain, there are some positive ongoing studies showing efficacy in some rheumatoid arthritis, as well as psoriasis with topical use. Again, small sample sizes and limited case reports in these, so and variability in the route of administration, so it's really hard to kind of make those clinical decisions. You just kind of have to make your best guess. And I will not be a pharmacist without talking a little bit about pharmacokinetics. So a lot of these, similar to Dr. Fan's discussion on cannabis, CBD is very fat soluble, it's lipophilic, so there's a lot of things that can affect absorption. Specifically, if a patient's taking it orally, having a recent high-fat meals can increase the levels, as well as if they're smoking it, how they're smoking it, how much, how often, how long they're holding their breath, the device that they're using, all that can kind of affect the absorption as well. Time to onset, similar to what Dr. Fan said, is with oral, it's going to be a longer time to onset, but a longer duration. So it can make it really hard to titrate to an appropriate dose for the patient, but it might be useful for patients who require symptomatic relief for longer periods of time because it lasts longer. Whereas the inhalation, administration, rapid onset, short duration. And then side effects, you're going to see basically the oral side effects with the inhalation as well. So a lot of CNS depression, or a lot of CNS, so sedation and somnolence, GI, which will be discussed in the next talk. And then hepatic enzymes, there was a study, actually hepatotoxicities was reported with high doses of the cannabidiol oral solution that was approved for seizures. So it actually caused patients to have to dose reduce other seizure medications because of that. Let's see. So CBD is primarily metabolized through the liver, CYP2, C19, and 3A4. It has been known to inhibit 2C19, 3A4, 2D6, and 2C9. The CYP3A4 inhibition may result in considerable interaction with our CFTR modulators. So it further highlights the need to routinely screen use in a very non-judgmental manner with our patients to get as accurate report as possible of what our patients are doing. And it also should be noted that in clinical studies with the cannabidiol, the incidence of LFT elevation of greater than 3 times the upper limit of normal was 13 to 17% with cannabidiol versus 1% in placebo. So patients using both ETI or modulators as well as CBD may have a compounded effects and increased risk of elevated LFTs. Most drug interactions are associated with concurrent use of CNS depressants. So you're going to have the synergistic sedation and hypnotic effects with high doses. So patients who are also on benzos, for example, might have more sedating effects. And then as far as drug interactions, I only listed some of the major ones that you would probably kind of expect. But I did want to focus on the drugs that have narrow therapeutic indexes, such as the cyclosporin, tacro, and warfarin. These can have big implications, especially for our transplant patients on tacro. So it is important to note that these can cause increased serum concentrations in the drug, and those levels should be monitored appropriately. So unknowns and unanswered, there's a lot of things that we don't know because we just don't have the studies. But we do know that CBD can pass through placenta. So it's recommended in general to avoid CBD and these agents during pregnancy and breastfeeding in general. But we just don't have data on how it affects the fetus and things like that. We also don't know a lot about cumulative exposure. So what happens if you eat food that has the CBD in it, you're also using a CBD-infused skin cream, and then you're smoking it the same day? Like, what does those different routes, what does that cumulative exposure look like? We also don't know long-term effects on our patients. A lot of these studies were, like Hannah said, one dose, very short durations. As well as the toxicity profile when it's administered different routes. A lot of these studies looked at just oral administration, but we don't really know how that differs if it's inhalation versus topical and other routes. And then our special patient population. So how do these products affect the elderly, children? What about those patients, those kids who are getting secondhand smoke exposure from the parents who are smoking the CBD? We just don't have a lot of that data. And a lot of our patients who have CF, there's not that many studies. Actually, there's no studies that I found of CBD use in CF patients. And as a care team, some things to consider pertaining to CBD in our patients. So it is important to review the patient use in a non-judgmental manner. We want our patients to be open and honest with us. Patients may assume that they are effectively treating their medical condition, and so not seek medical care, and that can also delay accurate diagnosis and treatment of a medical condition that they may be trying to treat at home. And it's important to know your state laws pertaining to CBD possession and use. So while federal law does allow the sale of CBD, some states do not. So it's important to know where your patients are located, where you are, all the laws that surround the states around you. You just don't want to get them in trouble. And then discussing concerns with our patients for use and lack of regulatory oversight. So we want our patients to be aware that the FDA doesn't regulate the claims of benefit, and that they have issued warning letters for false claims. And then there are, these products aren't tested they aren't labeled for accuracy or safety or effectiveness. So it's impossible to know the exact dose that a patient may be taking if they're just buying it over the counter. So it is important to educate our patients to look for independently tested products. So anything that has a certificate of analysis on it means that an independent lab's assessment of the product's potency, it's been assessed by an independent lab. So, and then they also look at contaminants as well. And then if able, patients should obtain their products from medical dispensary if possible, because these products are more regulated. They tend to have the certificate of analysis. They tend to be, more kosher. And then the general approach, as with all drugs, should be to start low, go slow, and stay low. We want our patients to be on the lowest, most efficacious dose to minimize side effects. There are no established dosing guidelines, so we want them to stay as low as possible. And then the importance of shared decision-making and patient education. So it is important to include patients in care plan and clinical decision-making. So we want to be able to discuss all the pros and cons with patients to get their buy-in and investment in their health. Like we want them to know, we want them to know all the information so that they can also make an appropriate decision whether or not to use CBD or THC for that matter. And with that, we'll take questions.
Thank you, Dr. Fauci. Okay. If CBD alone is not effective, why is its use when taken orally so popular?
Can you repeat that?
If CBD alone is not effective, why is its use when taken orally so popular?
Some studies have shown that CBD is effective in certain situations, anxiety, for example, and seizures. I think taking it orally is becoming more popular because it's easy for dosing accuracy, or it's easier for patients to take it rather than mixing it in their tea or things like that, just for dosing accuracy purposes, probably.
What is your recommendation for monitoring, example like LFTs, or dose adjusting those on CFTR modulators?
Good question. I mean, we get, obviously, as with you all should, if a patient's starting out on a modulator, you should be monitoring those LFTs routinely at first. And then we get annual labs. Honestly, I don't ask about this enough in clinic, but I think if you're aware that your patient is using these products routinely, it might be a good idea to, check those LFTs more than just once a year, maybe every 6 months or so, depending on if they're having any side effects or anything.
Are there any studies on the long-term effects on cognitive function and emotion that you're aware of?
There aren't any long-term studies that I know of that have looked at the long-term. The study that looked at like emotional liability and things like that was very short. It was just a 1-day sort of study. So I don't think that there's any studies out there that have looked at the long-term effects. It would be nice to know that. So for moving forward, it'd be a good thing to look at.
I have a question too. What are your thoughts on like the adverse effect profile or safety profile of like a CBD product versus like a conventional product for anxiety, like benzos or opioids for pain, especially in our population?
I think that's a tough question.
Could just be your opinion. Doesn't have to be a study.
I think it would probably depend on the patient. There have been studies that have shown that CBD in substance use disorders, so patients who are using opioids, it has shown to help them come off and not have the withdrawal. So if a patient has a history of, it would depend. So I wouldn't want to use like benzos in a patient who has a history of substance use disorder. So CBD might be an option there. It would depend.
Some shared decision making.
Yes,
perhaps?
shared decision making, perhaps.
Hi, Dr. Fouché. Fantastic talk. My name is Sherry Willie. I'm a dietitian at University of Louisville. My question for you is, you mentioned that many products may have CBD in them. They may not have the correct dose. Potentially, it may be an unexpected ingredient. So as a clinician, when I'm talking to a patient and they're disclosing that they are using a supplement, do you have a good resource that is easily accessed to look up these products to be able to better understand what is in the product or what the dose is to provide appropriate education?
Honestly, if they're buying it from just an over-the-counter dispensary, it's going to be really hard to know that dose because it's not regulated. I think just making sure the patient's educated to know that those are the risks and that it's potential that they could be ingesting THC and not realize it. If they do have like a certificate of analysis that it helps me sleep better at night because I know that it's at least doesn't have contaminants and it's actually been looked at for dosing accuracy.
Thank you.
All right, I think that is good. Okay. Thank you.
We'd like to welcome our next speaker, who is Candace Shemtab. Candace is a registered dietitian with the Adult CF Center at Central Florida Pulmonary Group in Orlando, Florida. She also serves as the research dietitian. In her role, she has organized the CF Education Day and other programs for the Central Florida CF community, as well as providing community education for healthcare professionals at local hospitals. She is actively involved in CFF QI initiatives and has served on the local Orlando Cystic Fibrosis Foundation Board. Welcome, Candace.
Sorry, a little technology thing. Okay, well, welcome everybody to GI effects of THC and CBD. I'm Candace Shuntaub. I'm the registered dietitian and a CF researcher at Central Florida Pulmonary Group, Adult Cystic Fibrosis Center in Orlando, Florida. I have nothing to disclose related to this presentation. Today we're going to talk about a brief history of cannabis, the endocannabinoid system, the use of medical cannabis and CF, GI effects of THC and CBD, some evidence-based recommendations, ongoing research, the hyperemesis syndrome, and then we'll just come up with some conclusions. A little bit of this may overlap with what our previous speakers talked about. So just a brief history of medical cannabis. For thousands of years, cannabis has been recognized for its medicinal properties, particularly pain relief. Cannabis was commonly used in medications in the US before 1937 when the Marijuana Tax Act made it illegal. Cannabis is currently a Schedule I substance under the Controlled Substance Act. And in 1996, the California Compassionate Act legalized medically necessary use of cannabis. In 2018, the Farm Bill made it legal to grow hemp and cannabis with very low THC, and this made CBD products federally legal. But as you heard from our previous speaker, that's not so in every state. What is cannabis? I think we've already heard that it's a plant indigenous to Asia. There's 3 species. Cannabis sativa is the most common in the West, and the active ingredients are called cannabinoids, and there's more than 100 identified in botanical cannabis plants. The most predominant are THC and CBD. So, really very interesting. To understand the effects of cannabis, we need to discuss the endocannabinoid system. I have a little bit different take on this than the previous speaker, so I'll go through this kind of quickly. It's a vast network of chemical signals and cellular receptors throughout the body. I found it fascinating that this major body system wasn't even discovered until the 1990s, and I think this is kind of reflected in our overall knowledge about cannabis in general. The physiologic roles of the endocannabinoid system continue to be studied and it's implicated in immune, metabolic, nervous, and nervous system homeostasis. The endocannabinoid system regulates many diverse responses in the body, such as appetite, mood, pain, inflammation, and is involved in reward circuitry. THC and CBD exert their effects in the body through this system. So as you heard before, there's 2 types of cannabinoid receptors. There's CB1 and CB2. The CB1 are represented by the blue and the CBD by the orange, and you can see that they really are throughout the body. Just a little bit about this. There are 3 different types of cannabinoids that stimulate the endocannabinoid system. First of all, there's endocannabinoids. So these are endogenous products made by our body, and they are chemically similar to THC and CBD from the cannabis plant. There are 2 main ones. They're 2-AG and amenadides. As you can see, they interact with CB1 and CB2 receptors. Then there are botanical cannabinoids. They are derived from the cannabis plant. THC has an affinity for CB1 receptors, and CBD really pretty much they act through the CB1 and mainly CB2 receptors. Then we have the synthetic cannabinoids, and the THC ones are Dronabinol, which the trade names are Marinol, Syndros, and Nabilone, and then the CBD, which is extracted from the cannabis plant, and 100% is called Epidiolex, and as was mentioned in previous lecture, that is used in seizures. So I would like to turn our attention to why CF patients use medical cannabis. This was a survey of CF patients done by Stephen et al. And published in 2020. Relaxation and pain were the top two reasons for CF patients to use cannabis. And then it's also not surprising that they use it for appetite stimulants and for nausea. So let's dive into the GI effects of THC and CBD. So I'd like to first point out that there is very little data specific to CF patients. So the information that I'm presenting, we really have to take a leap and extrapolate it to CF patients. Most human research has been done in cancer, AIDS, and most recently inflammatory bowel disease. With that being said, we know that it improves appetite, reduces nausea and vomiting, and reduces pain and possibly abdominal pain. So let's first talk about the effects of cannabis on appetite. We're all familiar with increase in appetite with cannabis, vernacularly known as the munchies. As in the previous slide, I'd like to remind you that many CF patients use medical cannabis to increase their appetites. So in 1986, the FDA approved Marinol. This is a 100% synthetic form of THC. It's a Schedule III medication. For any caregivers out there, just so you know, it's formulated with sesame oil. Marinol is approved, FDA approved, for the treatment of anorexia associated with AIDS, nausea and vomiting associated with cancer chemotherapy. It is not approved, FDA approved for cystic fibrosis related nausea, vomiting, anorexia, decreased appetite, or weight loss, and often this can really complicate getting Marinol approved for our patients. Okay, so here's a study. It's a randomized controlled study of 139 AIDS patients. This is using a visual analog system on the y-axis to assess the appetite, and on the x-axis we have weeks. There was an improvement in appetite from baseline seen over 6 weeks of administration. They received 2.5 milligrams per day, twice a day, of Marinol, and this was sustained for 6 weeks. These results were statistically significant. And also of interest, the subjects gained 2 kilos and reported improvement in mood, but that did not reach statistical significance. 18% of the patients reported side effects taking Marinol, which were feeling high, dizzy, somnolence, and changes in blood pressure. These are the results of a 2015 Cochrane Group meta-analysis. They looked at 441 studies, but only found 23 that met their criteria for non-biased randomized studies. These studies used THC in the form of Marinol and Nabinol, so none of this was botanical cannabis. The meta-analysis showed that THC was effectiveness was similar to traditional antiemetic medications such as compazine, and synthetic THC medications, when compared to placebo alone, were 5 times as likely to resolve vomiting and 3 times as likely to stop nausea and vomiting in cancer patients. Then, this is a study, and more recently, of 81 patients given an oral THC to CBD in a 1-to-1 ratio medication, which was added to traditional antiemetic regimens in patients with refractory chemo-induced nausea and vomiting. The addition of the THC-CBD to standard emetics was associated with an improvement in functional living scores and quality of life. But They did report a lot of side effects. 1/3 of the participants experienced moderate to severe adverse events such as sedation, dizziness, and disorientation. So this is actually a survey, and this is looking at botanical cannabis. This is 1,120 patients enrolled in the cancer patients enrolled in Minnesota's medical cannabis program. This was not controlled for dose, strength, or administration route of cannabis. The baseline scores were compared to scores 4 months later for 8 different symptoms. It was statistically significant to p is less than 0.001 for all symptoms. Along with improvements in anxiety, appetite, sleep, there was also a decrease in nausea and vomiting reported. I would also like to point out pain. The pain reported was at 97% at baseline and was reduced to 30% after 4 months of cannabis administration. So that leads me to this slide. As previously mentioned, for centuries, cannabis has been known to relieve pain. Specifically, there's a little bit of evidence that it can reduce abdominal pain. This is a study of 24 patients with abdominal pain related to gastroparesis. These are not CF patients. All patients' symptoms were refractory to standard therapies for pain and gastroparesis. The patients were prescribed either Marinol in 2 to 10 milligrams per day, medical cannabis, or both. As you can see, along all 3 treatments, there was a statistically significant reduction in reported abdominal pain scores. So let's get to the bottom line here. The 2017 National Academy of Sciences evidence-based analysis on the health effects of cannabis and cannabinoids came up with recommendations. None of these are specific to CF, and I actually took out things that weren't really related to the GI tract, I have to admit that. So they found conclusive and substantial evidence that cannabis is effective for treatment of chronic pain in adults as an antiemetic in the treatment of chemo-induced nausea and vomiting. There is moderate evidence that cannabis is effective for improving short-term sleep outcomes, but there is limited evidence that is effective for increasing appetite and decreasing weight loss in AIDS patients, and also improving anxiety symptoms. So there's been a lot of emerging information, research, in bench, animal, and some human studies, providing better understanding of the GI effects of THC and CBD in humans. So they found some interesting results, such as decreasing lower esophageal sphincter pressure in the stomach, decreasing gastric emptying, and decreasing gastric acid secretions. And in the intestines, there's been a lot of interest in inflammatory bowel disease, and they found that it could slow down colonic transit time, and it may affect the microbiome and intestinal permeability. These are preliminary findings, but you could also see how cannabis use could have a detrimental effect on our patient given these emerging results. Take, for example, slowing down the colonic transit time for our chronically constipated patients, or in delaying gastric emptying time. So I'd like to show you just one slide. This is a very small study. It's only 13 humans, and they were given a meal that had isotopes in it. And over 2 hours, they looked at the difference of patients being given THC and the placebo group. And after just 30 minutes, they could see that there was a difference in gastric emptying of the THC group versus the placebo group, and that continued until the 2-hour mark. I would like to point out here that at the 2-hour mark, the patients given THC only had 20% of their meal released by the stomach. These results are statistically significant. As ongoing research continues on the GI effects of THC and CBD, it will help us to treat and guide our patients with significant GI symptoms. Okay, probably looking at the big crowd here, There's a lot of enthusiasm about medical cannabis. And a lot of that really exceeds our knowledge in this area, particularly in CF. The excitement about cannabis is reflected in a 2021 Gallup poll that showed that 68% of Americans believe that cannabis should be federally legalized. So with all the popularity of cannabis, there's also been an increase in the cannabinoid hyperemesis syndrome. And I just wanted to play you a little snippet from Good Morning America, because I think they actually explained it really well and show a patient who suffered from it.
Good morning, Gigi. Good morning to you, Robin. You know, most people don't think of
Oops.
cannabis as making you
Oh,
violently ill, but
There's
some
no
people
volume.
develop this condition after consuming high concentrations of cannabinoids over long periods of time. And this rare illness is being reported far more often with the legalization of marijuana and higher potency and greater variety of cannabis products, from vaping to edibles.
When Erica Hagler was 33, the otherwise healthy artist was struck down with a severe mystery illness.
Felt like I was going to die. Shakes, elevated heart rate, completely dehydrated, and the vomiting was back to back to back.
Erica was in the hospital for 2 weeks with no diagnosis. She says her doctors assumed she was suffering from a neurological or psychological disorder.
They tested me for everything else underneath the sun. I actually had the doctor walk into my room and say, "We're sending you home because we can't find anything wrong with you."
Soon after, Erica, who says she was using cannabis multiple times a day, learned about CHS, cannabinoid hyperemesis syndrome, which affects people who use high doses of marijuana daily over an extended period of time.
How did you get the diagnosis?
I diagnosed myself. Then I went back to my doctor and I said, "This is what I think I have." And then he said, "Oh, you know what? That sounds right. I've heard of this."
CHS is a rare condition that causes bouts of vomiting and abdominal pain.
Okay, I cut that short because it's actually kind of long. But I think that really explains this syndrome pretty well. If you have a patient that comes in and says they can't stop vomiting, there actually is a quick thing you can ask them. You can ask them if they take hot showers and maybe get in the bathtub and they feel better. That seems to be something that might really hint towards them having this hyperemesis syndrome. So I think generally as CF practitioners, we need to discuss patient use of cannabis with our patients. I'm actually quoting your survey, Corey. Basically, we found we don't do a very good job at discussing this with our patients. 15% of CF practitioners spoke with their patients about cannabis use, 48% only sometimes, and 41% rarely. We really need to discuss the risks and benefits and the many adverse side effects of cannabis use, and then safely obtaining cannabis through state-regulated dispensaries. But I did want to let you know, not only do not every state have medical cannabis programs, but even if they do, it can be very costly to get your medical marijuana license in some states. It could cost you up to $500, so that might actually be a barrier for some of our patients. But it's really our responsibility to lead these discussions because we know there's plenty of misinformation out there. When I Googled CF and medical marijuana, I was really just aghast by what I found. This is just one of hundreds of ads from companies out there. And this one says CBD can enter the lungs, bind with endocannabinoid receptors to improve lung function and reduce mucus. I was really shocked by some of these claims. And then even on the cff.org website, the only thing I could find on medical cannabis was one patient testimony about them using medical cannabis. So I think that we need to do a better job at discussing, informing, and educating our patients about cannabis. And if we don't, somebody else will. So just to conclude, we're really with the GI effects of THC and CBD, and then you heard the previous speakers too, Let's be blunt. We're really only at the tip of the iceberg here. So we need a lot more research, a lot more discussing and education of our patients. We need specific research to CF. And I really hate to be a Debbie Downer, but a lot more information is needed on this topic. Thank you for giving me the opportunity to speak.
I have a question. So, anecdotally, at least, do you guys ever use dronabinol for your patients for appetite stimulation or weight gain? And if so, what's been your experience with that?
Actually, our experience has been very positive with that. Our physicians support the use of Marinol, especially when other medications don't work. Okay, this would be anecdotal, but I would say by far the large majority of our patients are tolerating it. But there are those few patients that have the known side effects of feeling high or dizzy, and they don't tolerate it, but we do regularly use Marinol. Okay.
How do you feel it compares to side effects with like cyproheptadine, which I feel like is pretty commonly used for appetite?
Oh gosh, I'm not really sure how to answer that question.
Anecdotally.
Yeah, I think anecdotally it's probably about the same. Yeah. Okay.
Hey, thank you. I was typing this into the chat and then I was like, this is a really long question, so I'm just going to go. Yeah. I really appreciate that you talked about cannabis hyperemesis. I feel like we see an increasing number of our pediatric patients who are admitted to the hospital for kind of the repetitive cannabis hyperemesis vomiting, as well as increased vaping use in our CF patients. And it's been really challenging because there's this perception that, cannabis use is good for nausea. So our patients who then start to experience hyperemesis then use more and more because they think that it's going to help, and it's having the exact opposite effect. But I was wondering, how you approach that conversation with patients and what are the treatments that are recommended for hyperemesis?
Okay, that's a good question. Honestly, we haven't experienced that in any of our patients, and we're an adult center. So I haven't specifically had that talk. But what I do know, if a patient ends up in an emergency room, of which there's many, many more admissions for hyperemesis syndrome, that basically, I believe, and I've got some pharmacists here, but I believe they're being treated with Haldol in the ER. And I would say it's just a matter of opening up those talks because, as Corey's survey showed us, as CF practitioners, we're just not really talking about cannabis with our patients. And since there are such serious side effects, I think it's probably time to do that. Did that answer your question?
Yeah, thank you. I know we also use the hot showers and things like that, and capsaicin cream can emulate some of the effects of similarly to taking a hot shower. But I was curious if there were other things, but thank you very much.
Yeah, thank you.
Hi, thank you for your talk. I'm a social worker in a CF center, and I'd really love to see if we can expand this talk also talking about things from a mental health perspective. So that's why I'm here to say that we screen every patient once they turn 14 for substances. And the way that we've done that so it doesn't feel so burdensome is part of the annual mental health screen. So we have chosen a screener that is validated mostly for adolescents and young adults, but we're using it for older adults because we find it actually gives us information like what substances are you using and how often are you using them. So I just want to put that plug out there that this is possible to do. And when I started doing this, lots of the providers like, I had no idea they've been vaping cannabis for 5 years. And I was like, how do you not know that? You've been treating them for 10 years. So I think it's just really important. I'm also loving this talk because as a social worker, patients are like, these are all the benefits I have, so why are you telling me I shouldn't be smoking or vaping? And I'm like, that's a great question, and I don't have evidence. So I'm loving that this stuff is available. And a similar question was asked earlier, like, where do we send patients who are looking for evidence about why they shouldn't be using cannabis in any of its forms, or like, what are the negative side effects?
Okay, that would be like a really long answer.
Yeah.
First of all, you know, your point about the screening is excellent, and I think that's something that probably everybody in the room is going to take home with them. So in terms of, you know, the side effects and all that, they found it in every single study. And honestly, I was really shocked by the number of patients that had, you know, adverse effects. Because, you know, in one of those studies, it was a third of the patients were dizzy, somnolent, you know, confused. I mean, those are pretty serious side effects. And maybe, probably a PharmD might be better at speaking to some of the other side effects of, you know, THC and CBD. Pretty much, I'm looking at it from the clinical and research side. But does that kind of answer your question?
It does. I apologize that it was more a mental health spin and I was on my soapbox, but I do appreciate the talk, because I do have a lot of patients who have asked about using cannabis instead of some of the other medications because they have frequent nausea. They're like, I'm already using Marinol. Why can't you just give me medical marijuana? I'm like, well, I'm not the GI specialist. You should talk to your GI specialist. But I think it's important.
I mean, one thing you could tell them right off the bat, there is a risk. Especially if they're not getting from a state dispensary. I mean, marijuana has been known to be laced with fentanyl and be deadly. So, I mean, right there, that would be scary enough.
Yeah. Thank you.
I think. Yes.
I think my thunder just got stole because I had that same aha moment that we're screening patients already for anxiety and depression. And it's almost like if we're not going to talk about it when we do that, they're going to find out about it if they haven't used it previously. Yeah. The other question is that as with patients with distal intestinal obstructive syndrome, I wonder how these products would play into their intestinal motility at a lower level, aside from just hyperemesis.
Yeah, and that is in that one slide I was showing. You know, we know that it decreases gastric emptying, but there actually is quite a bit of research out there. I just didn't put that slide in because inflammatory bowel disease is looking at slowing down colonic transit time as a positive because their patients tend to have more diarrhea than they have constipation. So I think we are really, as practitioners, we have to be very careful that, you know, we know the causes of possibly constipation in our patients because it could definitely complicate that.
Okay, we have some app questions too. Do you feel there will be more research on pediatric patients, especially those experiencing failure to thrive, whether related to CF or otherwise, given the increased access that underage children seem to have, whether legally or illegally, especially in the form of vaping?
Oh boy, that is like, okay, let's break that down just a bit, okay. First of all, from my reading in this subject, I mean, cannabis is not good for the developing brain in general. So I would say we would probably need an expert in the developing brain to be speaking to you guys on that. But in general, I would say I would use a lot of caution, first of all, in pediatric patients for the possible effect on their developing brain. And then what was the rest of it?
I think that's...
Yeah, I really can't see using it in patients, pediatric patients.
Who do you think on the team should be asking this? Is this pharmacy, even though this is not an FDA-approved drug?
Okay, good question. We unfortunately don't have a pharmacist. I'm really jealous of everybody who does on our team. But I mean, I think it could really be a joint thing between the physician, the social worker, and the dietitian, because it really touches all of our disciplines. I think it's just a matter of finding out who is most interested in discussing this with our patients and who's most equipped to handle that.
We have one more.
Hi.
Hello.
I have a huge issue, just because I work in pediatrics, and we do other things besides CF, and we've had quite a few patients of perfectly healthy teens that got vaping syndrome, and ended up on oxygen.
Yeah.
I have a hard time saying it's okay to vape anything.
Yeah, I agree with you. Last year, I talked on medical cannabis in general, and there was a big study. I think it's called EVALI, EVALI, but it looked at all the effects of vaping. And, you know, vaping has really detrimental effects. That was looking mainly at the lungs themselves. So I completely agree with you that, you know, unfortunately, vaping came out and they tried to sell it as a really safe alternative to smoking. And some people just are completely unaware that vaping is actually very bad for your lungs. And we don't actually know how bad it is because there's chemicals in there and they can vary. Does that?
Well, yeah, but I break it down. I have a saying to any of our teens that tell me that they're doing any of this. I always say to them, because you already have a lung disease, it's better to eat. If you need it, eat it.
Absolutely.
And I break down the vaping because if you just think about it, and this is for anybody, and this is my soapbox. If you think about it, what is vaping? They're taking an oil and heating it up. So then you're putting, and it doesn't matter what it is, you're putting hot oil on mucus cells. That's gonna burn them. That's gonna burn them. It doesn't matter what it is. And then you think about how are they heating it up? They're using metal coils made of something that also may have toxic, as it gets heated up, is expelled and inhaled. And it's all done by a battery. So like when you break it down for people, like it doesn't matter what it is, whether it's CBD or tobacco kind of oil, any of that is not okay. And when I've seen a 16-year-old who was an athlete that was brought to her knees and couldn't walk down our hallway without oxygen, all because she was vaping, I can't say, you know, it's okay, go ahead and use it, you know? So, I mean, that's my soapbox. So I always say eat it. And so, like, is that a good statement to say or is it not?
Well, I mean, we're dealing with patients with a lethal lung disease. And as far as just even logically, I mean, you don't want them to smoke. And I don't think the verdict is out on how bad vaping really is. I am not an expert on it, but I can try to locate that study, which really looked at those long-term lung effects of vaping, and it was not good. So
Thank you.
Thank you.
Okay.
All right, our final speaker today is Dr. Renee Dagenet. Did I say it right? Okay. Dr. Dagenet is the clinical pharmacy specialist at the St. Paul's Hospital Adult CF Clinic in Vancouver, British Columbia. After receiving her Bachelor of Science in Pharmacy from the University of British Columbia in 2015, she completed a pediatric hospital pharmacy practice residency in Lower Mainland Pharmacy Services in 2016, then received her post-baccalaureate PharmD from UBC in 2018. She joined the Adult CF Clinic in February 2019 after working at the St. Paul's Hospital Outpatient Hemodialysis Unit. Dr. Dagenet is actively involved in clinical research and is passionate about patient advocacy as well as teaching and mentoring learners in the pharmacy profession.
This is the most down here. Perfect, thanks. Oops. Awesome. Hi, thank you so much for the opportunity to speak. I'm really excited to be here with you all today. I don't have any disclosures to declare. And so this is a list of learning objectives that we're going to go through today. So I'm going to describe some cannabis usage trends in people with CF. So overlap with some of the previous speakers as well, talking about prevalence, frequency, formulations used, and medical indications. Describe the people with CF and healthcare providers' reported perceptions about cannabis safety and effectiveness, and discussing some strategies for healthcare providers to establish open communications with patients about cannabis and some potential barriers to this communication. So to set the stage for this, I'm going to go over a study that we did at our site. Sorry for talking about the usage trends, called the Vape study. And if you haven't already, I encourage you to go see poster 623 to get more details on that study and our findings. But in short, we sent an electronic questionnaire out to all the patients at our clinic in Vancouver, BC, which is comprised of adults with CF and CFTR-related disorder. And our primary objectives were to look at the impact of cannabis legalization in Canada, and that was in October 2018, on use and perceptions, as well as the EVALI, or e-cigarette vaping associated lung injury, the media attention, and the impact on people's perceptions of vaping. And we had some additional secondary objectives looking at usage and perceptions, and then strategies to improve communication with our team. So in total, 110 individuals completed the questionnaire, 28% of whom had never used any cannabis-containing products. And of those who had ever used cannabis products, the majority considered themselves to be current users, and they comprised of 43% of all respondents. So in terms of formulations used by those 47 current users, edibles were largely the most used and preferred formulations, followed by vaping with an e-cigarette or other handheld device, as well, and then smoking with a joint or blunt, or using tinctures were the third most used, though smoking was more preferred of the two formulations. And reasons reported for preferring the formulations were convenience of use, onset and duration of action, and then also lesser potential to harm the lungs when it came to non-inhaled formulations. So this is a bit of a busy slide, but essentially of the 47 current users, 40 of them were using cannabis medically. So in the left column is a list of symptoms that we asked specifically about whether or not they were using cannabis to treat. And in the middle is the proportion of those who were using it for that symptom who found it to be very or somewhat effective. And on the right was very or somewhat ineffective for those who were using it. So the three most commonly used treated symptoms that they were using it for was insomnia or lack of sleep, stress, and anxiety. But still at least 50% of people were using it for joint pain, low appetite, and depression. And then additional symptoms we asked about were abdominal pain, migraine and headaches, chest pain, nausea, airway inflammation, and sinus pain. And notably, the majority of individuals who were using the cannabis medically did find it at least somewhat effective for their symptoms. And also important to consider is that almost 2/3 of the current users reported that cannabis had somewhat or significantly improved their quality of life. So now I'm going to compare our findings to some other literature, and due to limited time, I'll only have the opportunity to talk about a couple of the studies that are out there. One of which was also conducted at our site about 10 years prior to the Vape study. And so they were specifically looking at medical use of cannabis outside of the Health Canada medical cannabis program. And so of the 76 respondents, a quarter of them were using it medically. And the specific medical indications evaluated were appetite stimulation, sleep, pain, anxiety, and bronchoconstriction. And the majority of individuals did find it effective for a significant improvement in those symptoms, particularly for appetite stimulation and sleep. And though not reported on this slide, it's important to mention that 5% of individuals reported worsening of anxiety and 6% reported worsening bronchoconstriction. When looking at the impact of cannabis on the CF-related quality of life, so before cannabis use and after, it seemingly had a positive effect on people's CF-related quality of life. So specifically, there was a decrease in the proportion who rated their quality of life to be impacted moderately or severely by their CF, and more reported it to be affecting quality of life mildly. So next is a study by Stephen et al., which has also been touched upon by one of the other speakers. So they did a study out of 6 CF centers in New Jersey and Pennsylvania to evaluate the use and attitudes towards medical marijuana. And they sent an electronic questionnaire to all individuals aged 16 years or older at these sites. So they had a total of 89 respondents, 17% of whom were using marijuana medically. And of the respondents to the question, so 156 individuals, when asked if they would be interested in medical marijuana if it was available, another 46% indicated that they would. They also looked at used and preferred formulations. And so the top 3 used and preferred were the same as for the Can-Vape study, so the edibles, vaping, and smoking. And their 4th most preferred was oils, versus the Can-Vape study, which was tinctures. They looked at a number of medical indications for use. So at least 50% of individuals in their study were using it for relaxation, pain, appetite, and insomnia, but still at least a quarter were using for nausea, depression, dyspnea, migraines, and arthritis. And when considering the effectiveness for these symptoms, 90% found the medical marijuana to be highly effective, and very few found it to be not at all effective for the symptoms. And the majority of individuals rated the medical marijuana to be either important or very important to their health, and another almost 20% found it to be at least somewhat important. So in terms of how people with CF perceive the safety and risks of cannabis, so in the Can-Vape study, when we asked, current users were more likely to report that cannabis is less likely than cigarettes to cause addiction or dependence, cause physical harm, or negatively affect mental health when compared to those who were not current users of cannabis. And current users were also more likely to report that the potential short and long-term side effects associated with cannabis use were not concerning. So Hamburger and colleagues also conducted a study out of the Stanford CF clinic, and they were assessing the use of perceptions and usage of and short and long-term side effects associated with cigarettes, e-cigarettes, and smoking marijuana among adolescents and young adults with CF. So I'm going to be focusing on the results related to smoking marijuana, and later in the presentation I'll also touch upon results from a questionnaire that they had sent to CF healthcare providers. But of the adolescents and young adults so specifically aged 13 to 26 years old who had responded, almost a third of them had smoked marijuana at least once in their lifetime. The study participants were also asked to rate their perceived risk for a list of outcomes on a scale from 0 to 100% for someone who had just started smoking either cigarettes, e-cigarettes, or marijuana 2 to 3 times per day. And so specifically, the outcomes they looked at were worsening cough than normal, immediate exacerbation or within 6 months, need for antibiotics, the need to be hospitalized immediately or within 6 months, to die sooner, or to become addicted. And respondents overall felt that smoking traditional cigarettes carried a higher risk for each of these outcomes when compared to smoking marijuana. And they felt that the e-cigarettes carried a higher risk for all of these outcomes, except for the risk for CF exacerbation immediately or need for immediate hospitalization. When assessing perceived risk of each outcome, these adolescents and young adults who had ever smoked marijuana, i.e. the ever users, had generally perceived lower risk for each of these outcomes when compared to those who were never users of smoking marijuana. So now for some healthcare provider perceptions. So also touching upon the study by Muirhead and colleagues, so they distributed an electronic survey to healthcare providers affiliated with the accredited CF centers in the US, and they asked about both cannabis and CBD use. So the majority of respondents were social workers as well as physicians or advanced practice providers, but there's still also nurses, pharmacists, and dietitians who responded. And at the time of the questionnaire being sent out, cannabis was reported to be legal for recreational use in the states of 19% of respondents, and for medical use in 60% of respondents. And CBD was reported to be legal for medical use in 56% of respondents, but around a third were not sure of the legal status. So the respondents were asked whether or not they would consider advocating for cannabis or CBD for specific indications. So even though this isn't asking them whether or not they felt it was effective, one could hypothesize that if they were willing to advocate for it, they might believe that there's at least some benefit for the symptom. So the top 4 reasons that individuals would have been willing to advocate for were appetite, pain, nausea, and anxiety. But there's still a number who would be willing to advocate for sleep, stress, depression, and inflammation. And for 13% of respondents, they would not be willing to advocate for any indication for cannabis, and for 6% would not be willing to advocate for CBD. So there was a number of reasons why they reported why they would not be advocating for cannabis, the top 2 being potential exclusion for lung transplant eligibility, as well as it being federally illegal. But there was also a number who, for the reasons I've highlighted here, that were for what I believe to be based on some perceptions of cannabis, so mostly related to safety, so concerns for addiction and effects on development of the brain, as well as the negatives outweighing any positives and no potential for benefit. And the reasons for not supporting CBD were not reported in the study. So given the lack of literature in the CF community, I also looked at literature for perceptions from healthcare providers in the non-CF populations. So these studies typically focus on CBD or cannabis, but in general, the trends were the same. So overall, healthcare providers felt that there's insufficient scientific evidence to support their use to recommend because they're deemed ineffective for treatment or relief of symptoms or medical conditions, although some exceptions were chronic pain, anxiety, stress, or sleep. But even in these cases, they felt that cannabis and CBD were less effective than other treatment options that are available. There was also several safety concerns such as side effects, exacerbation of mental illness, effects on neurocognitive development, risk for addiction, drug interactions, and then also lack of regulation. So as was touched upon, there's not consistent dosing and there can be contamination with THC products, particularly in the over-the-counter CBD products. And there's also the perception that legalization has normalized cannabis use and people feel that it's natural, good for you, and not a very big deal to use. And people might not be aware of these significant safety concerns. So now that we know a lot of our patients are using cannabis, how do we communicate with them about this? So in the CanVape study, we asked patients whether they felt comfortable talking to our team about cannabis or vaping, and we were happy to see that the majority were comfortable, but there was still 13% who were not comfortable and another 10% who were not sure. So Vaziri et al. Did a study to evaluate the use of marijuana, CBD, vaping, and smoking cigarettes in people with CF. And Dr. Vaziri kindly provided me with some updated results this past Wednesday. So it's hot off the press and not yet published. So you've seen it here first. But I provided a link to the original abstract, and there will be, my understanding, a full abstract being published shortly. But essentially, in their study, 29% of respondents were using marijuana and 22% were using CBD. And when asked about their communication about marijuana and CBD, around 3/4, or just over 70%, stated that their team was aware of their use. And when looking at the total of 226 respondents, around 81% indicated they'd be comfortable discussing marijuana with their team, and 87% would be comfortable discussing CBD. But fewer of them would be comfortable disclosing their use with their CF care team. And almost 1/4 would actually lie about the frequency of use if they were indeed using these products. And 10% said they would not disclose use of marijuana, and 5% would not disclose use of CBD. However, patients choosing to not disclose this is not the only barrier. It's also us as the healthcare providers. So as has been mentioned, we don't consistently evaluate cannabis use in our patients. So as mentioned in the study by Muirhead and colleagues, about 15% were always evaluating cannabis use, but just over 1/3 rarely or never were evaluating this. However, once it was determined a patient is using cannabis, there was more consistency in asking about the reason for use, method of use, frequency of use, and also providing education about risks and side effects. But there's still a number who either rarely or never delve into these really important details. So in the study, they also asked respondents who does and who should be asking about cannabis use specifically. So to answer the question that was asked earlier, here's some evidence for it. But so they largely indicated that physicians and social workers were already asking patients about it. But when asked who should be asking about it, they said that 91% indicated it should be physicians. But as you can see, there's still a large number, at least 1/4, indicating that it should be one of the other many individuals on the healthcare team. So ultimately, it feels like everyone's kind of pointing at each other saying, you should be asking about it, and it really could result in no one asking about it. So in the study by Hamburger and colleagues that I previously discussed, as mentioned, a questionnaire was also sent to CF healthcare providers. And so one of the questions asked about discussing avoidance of smoking marijuana to the adolescent and young adults with CF. So the providers or someone else at their clinic were seemingly speaking to most patients about the avoidance of smoking marijuana, but for 22%, it was only targeted at specific patients, and 4% never discussed it. There was many reasons why people didn't discuss it. I've highlighted 3 at the top here, which were based on mostly assumptions. So assuming that the patients already knew not to smoke marijuana, that someone else in the clinic would be talking about it, or that patients would have received this education either at school, from their parents, or from their general pediatrician. And also a number either would forget to ask or didn't think about it. Time constraints, as we all know, it's really busy in our CF clinic, and sometimes there's other priority topics to cover. Marijuana is already legal in their state, and also concern for offending certain individuals. So why is it so important for us to evaluate this? So first is that patients don't consistently report their cannabis use, and it's really important as healthcare providers that we do know about this, especially from a safety and potential interaction standpoint. And then also, patients don't consistently report when they've reduced or discontinued prescribed therapies for use of cannabis. So in non-CF populations, upward of upwards of 40% of individuals who had substituted cannabis for other products reported that they had not told their primary care provider. And some individuals may assume that their healthcare provider already knows about their cannabis use, and this was found in a study of women who were pregnant. And in this study also, about a third of respondents reported that their prenatal care provider had never asked about cannabis use, so they perceived that this was condoning their use during pregnancy. And there is evidence for potential harms of using cannabis during pregnancy, so this just highlights the importance of us really proactively looking into this for our patients. So another large barrier to discussing cannabis with our patients is our perceived lack of knowledge and comfort in talking about the topic. So again, in the study by Mir et al., when they asked respondents how prepared they were in answering questions about cannabis and CF, so just over a quarter felt extremely or very prepared, but just over a third were slightly and not at all prepared for it. When considering answering questions about CBD and CF, there was even less comfort talking about it. So around 6% were extremely or very prepared to discuss it, and even more so, slightly or not at all prepared was the majority. And similar trends were with discussing the difference between CBD and THC. So again, very few felt extremely or very prepared, and the majority felt slightly or not at all prepared to talk about these topics. But this isn't just in the CF community, so also looking in the non-CF literature, there was largely either a perceived lack of knowledge, so providers felt that they didn't know, and also in the studies when they did knowledge assessment, they typically scored low about both cannabis and CBD. And then this also translates into more lack of comfort or confidence in discussing or recommending these products to our patients. And then, of course, as a pharmacist, I was wanting to know what pharmacists in general have been saying on it as well. And so in addition to the above, they felt really unknowledgeable about pharmacokinetics and pharmacodynamics, which affected their ability to counsel on things like drug interactions. And they also felt unprepared to talk about these products with patients or other healthcare providers in general, especially with lack of regulations and guidelines to guide things. So how can we overcome some of these barriers in communicating with our patients? So one is to make assessment a part of routine care, and I think it was great to hear from the individual earlier that this is a part of their routine screening with their patients every year. And one thing I've learned is we should really never assume who does or who doesn't use cannabis products, which is another reason why to make it a part of routine care. And in the process of determining how to make it a part of your routine care, I think it's really important to discuss within your team what the roles are going to be. Is there going to be a certain individual who asks about it and someone else who follows up on particular questions, for example? And then if you have identified knowledge gaps, then I really encourage you to seek opportunities to fill these gaps and seek some additional education so that you can feel more confident in answering patients' questions or at least know where to look. And in the non-CF literature, at least, there has been some evidence that if patients perceive their healthcare providers are more knowledgeable about it, they are more willing to talk about it and discuss it with their team. And also super important is to create a safe space, so one that's free of judgment, it's open for discussion and has empathy as well. And so one of the CanVape study respondents had indicated specifically that they felt it's important for the healthcare team to understand that for some individuals, despite the known risks with smoking and vaping cannabis products or other products, that for them, they perceive that the benefits outweigh any of these potential risks and the potential for stigma and shame. So just to be aware of that when we're talking to our patients about this, that they very well probably know these harms and they're still deciding to use these products, but we need to make a safe space so they're willing to talk to us about it at least. It's really important also to be aware of your personal biases and assumptions about cannabis and how this may affect the way that you approach conversations with your patients, so similar to creating the safe space. And I really encourage you to be curious and ask your patients questions. So when did they start using it? How did they learn about it? What are they using it for? How are they using it? And this also can help you identify opportunities to provide education because, for example, in my experience, some people who are vaping didn't know that there's options that are sublingual that may perhaps have quicker onset than edibles, which is why they'd been vaping in the first place. So it's a really good opportunity for you to discuss that with them. And motivational interviewing is another form of communication. So I would consider it particularly in cases where there can or is harm occurring for these patients. And the patient is ambivalent to making these changes. So it's an opportunity to try and encourage them to make those behavioral changes. So I know that the speakers and I have gone over a lot of information today, and many of you may be feeling like this when it comes to your knowledge about cannabis, especially with people with CF. But my hope is that today you'll walk away with some key learning points so you can take the steps necessary to transform into feeling more like this, feeling confident and well-informed in discussing this with your patients. Thank you so much.
doesn't seem any questions have come in yet, but it seems like a thread of all of this is that maybe we need to have some resources for CF made. And I'm curious where that comes from and who makes it and who supports it, you know?
It's a good question. I think, you know, because as we've seen, there's a real lack of evidence out there. And I think what can be really powerful is even just anecdotal experience and people sharing what their experience has been. So for example, the questions earlier about the impact on liver function, we've had a couple of patients at our clinic who were on ETI and had elevations in their liver enzymes with no other changes, no culprits. And we asked them, and they were using, one was using 80 milligrams a day of THC or cannabis products, and the other was using 150. So, you know, we were able to provide some education. They reduced their dose, and can't say it's causative, but their LFTs did improve after that. So just things like that. So sharing experiences on how to apply kind of what is known to day-to-day practice. But yeah, I think it'd be definitely a good idea if there was some consensus guidelines even on how to approach this with our patients.
Really great job. I'm curious. I think it's really kind of profound, the numbers that show like overwhelmingly people who are using feel like it provides them good benefit. Do you feel like that's more like placebo effect, or do you feel like maybe like the research just hasn't caught up yet with some of the benefits that these products maybe do provide?
Yeah, that's a good question. And I think it's something that I keep in mind when having conversations with patients, just because the literature isn't always there to support its benefit doesn't mean that certain individuals might not experience a benefit. So I think just, you know, acknowledging that that's their experience, and then if it is, like, you know, if they're using it edibles and there's no other potential harms, then just kind of supporting them and providing them with the education that they need to make an informed decision. But of course, if there are potential harms that are occurring, then providing them with that information as well so they can make the decision. But so yeah, it's hard because if the patient feels that they're experiencing it, then in my experience, if we try and tell them otherwise, I think it can really damage the relationship and they might not be as willing to talk to you about it.
Hi, I'm Preston Arndt from Ventura, California. I've been counseling patients on cannabis in family practice and also in our CF clinic for the past few years. Thank you so much for bringing this up, because having 46% of our CF patients using once legalization is just around the corner, we're going to have a big problem. We're up against 30,000 and counting articles on cannabis, and for every negative, you're going to find a positive. I really appreciate what you said. We need to have that talk with patients, and it's okay if a patient asks you, "What's your opinion?" It's okay to say, "No, I don't know," but I have the ability to look at research and help you make a decision. Really appreciate the mantra. What would you say? If don't smoke, but eat. Yeah. But I think that's a really sound way to go about it. We know that cannabis inhaled does stun the cilia, and I think that's something you can bring up to patients, and that can maybe lean them away. Oh, no, I already have a compromised immune system, and this just does it more. I think that's one thing. But then again, we know that THC. There's research out of UCLA that it is a bronchodilator. It's a beta agonist. THC is. So then you're up against that. But it's okay. We just have to do our due diligence and even look at those articles that have 50 patients. Those are the articles that our patients are also looking at.
Yeah, thank you. And just to add to that too is there's some evidence, at least in epithelial cells, that THC can affect, impair and downregulate CFTR function. So impair function and downregulate its expression. So I think that's also something, particularly if people are smoking or vaping it, to say, hey, if you're on a modulator therapy, for example, you're actually counteracting that potential benefit that you could be having. And so that's something also to provide, because I think patients might not be aware of that. So, but thank you also for the points that you added. So
those are really good pearls for an arsenal to help, and that should probably be up on the CFF site about that. These are great.
Yeah, thanks.
One other thing, someone asked about where there might be some good tools online about CBD dosing and purity. I use consumerlabs.com. They're really good in the supplement area. They're a third party, and apparently they pick supplements off the shelves and test it for purity. as well as which ones contain THC with the CBD or just pure CBD. And I've used that in the past and found it to be really helpful.
Thank you. I appreciate that.
Hi, Renee. It's Pat from the clinic in Vancouver, as a social worker. Yeah, I'm just sort of thinking, I was thinking about the one patient that we've had that uses quite heavily and was vaping and smoking. And I think there were conversations that we had with that patient because they developed some lung issues related to, they thought it was related to the cannabis. And they were convinced to start using edibles and clean edibles because they were from the legal supply. Can you just briefly talk a little bit about that situation? Was that patient quite receptive when they realized what kind of damage could be happening with that product that was...
There's a couple of individuals I'm thinking of, so I don't know who, but that's okay. It's okay. I guess I can speak from general experience when talking to certain individuals. Yeah. So great question. I think it really varies. So there's some individuals you have repeat conversations with smoking and vaping, and I've also kind of learned that, again, just trying to preserve the relationship with them. If you revisit it too many times, they kind of put up a wall. But some individuals will say, nope. Edibles, it makes me feel really out of it. It lasts too long. I can't go to work. Whereas if I, take a hit of a joint or a vape, then I have a quick effect and it's all I need. Whereas some individuals, as I kind of alluded to, I had a conversation the other day and they were vaping and they had suspected potentially some hyperemesis syndrome. There was some other factors as well. And I said, you know what, in the past, they hadn't been open to talking about alternatives. And I said, now is a good time. And they weren't aware that sublingual formulations can have different pharmacokinetics versus taking it by mouth, like the edibles. So it was something that they were interested in. So I think just talking to them about the different options, ask them what they're using it for, like what is the goal that you're trying to achieve with the use, and then you can try and find something that works well to suit their needs. But some individuals, they're just gonna say, no, I know the harms, but I'm just gonna do it anyway. Yeah. So, but thank you.
That's great. Thank you.
No problem.
I have one last question and then we're out of time. Do you think in the CF population, are patients maybe more resistant to edibles or maybe don't have as good of experience because it's so fat soluble and they're not properly absorbing like the dose they're trying to take?
That's a great question because I think it was actually last year at the NACFC, someone had mentioned about taking edibles with enzymes. And I was like, oh, that's a great thing. I'll talk to the people who are not wanting to try the edibles. And so there was an N=1 and who did try it and they said they didn't notice a difference to be honest. So I can't really answer that, but but that's a good question. So if that was a barrier, you could ask them to take it with their with their enzymes and see if that affects it. But that's a good question.
All right.
Thank you so much.
Thank you, everybody.